Welcome, everyone. We're just closing a few doors here, but please feel welcome to move forward a little bit. I'm Amy Boski, and I am co-director with Jim Keenan of the Park Street Corporation Speaker Series in Health, Humanities, and Ethics. We're now actually at the beginning of year 3. And one of the ways that we've thought about this speaker series is that each year we have a general theme that extends across the year's speakers, tied in some way to health, humanities, and ethics, but each year a little bit different. And this year's larger theme is loosely constructed around the idea of the common good. And I can't think of a better person to begin this conversation with us tonight than Sandro Galea. He is going to be introduced by Phil Landrigan, who joins us this year at Boston College and is spearheading a new initiative in global public health for the developing Schiller Center. So Phil Landrigan is going to introduce tonight's speaker. Thank you.
Thank you, Amy. It's nice to see all of you here at this late hour. So it's really a very, very great pleasure to introduce Sandro Galea as our speaker tonight. I think your eyes are really going to be opened by what you hear here. I have known Sandro for almost 20 years. We first met around the year 2000 when we were living and working about a block from each other in New York City. So he's a physician, as you will have read in his bio. He was born in Malta, he grew up in Canada. He's dual Canadian-U.S. citizen. Told me he was an accidental immigrant to the United States, that he crossed the border and couldn't get out again. When I knew him, he was working as an epidemiologist, senior epidemiologist at the New York Academy of Medicine. And we were both in New York at the time of the attacks on the World Trade Center on 9/11. And we both got involved in that in different ways. Our group at Mount Sinai School of Medicine, where I was before I came here, got involved in doing medical follow-up of the 9/11 survivors, work that continues to this day and which has documented a number of persistent health effects. Sandro and his team at the New York Academy of Medicine did a brilliant series of studies looking at the mental health consequences of 9/11. And there's a lesson in this, in that whenever there's a big disaster, such as 9/11, such as a hurricane, there are not only physical health consequences, there are also mental health consequences, and a comprehensive response to the disaster has to encompass both. And he and his colleagues recognized that from the beginning. They did a series of studies which documented increased emergency room visits, increased rates of depression and PTSD, post-traumatic stress disorder, increased rates of substance abuse, much of which has since settled down, although the PTSD and depression continue in the population. It was just lovely stuff. After that, he moved on to Columbia, where he chaired the Department of Epidemiology, spent some time at the University of Michigan, and now for 4 years has been the dean of the School of Public Health in the South End at Boston University, where he has just elevated the School of Public Health to a new level. It was already a good school. He has made it a great school. It's in the top 10 in national rankings. Just 2 more fun facts about Sandro that I think will help a little, something that you can think through as you're listening to your talk and illuminate your appreciation of what he has to say. Number one, he's trained as an emergency physician. So even though he's doing public health, he also knows how to do things on a short fuse. And secondly, in keeping with that, when he was a young physician, newly trained, he actually worked with Doctors Without Borders in Somalia. Not exactly your favorite tourist spot in East Africa, but clearly the good work. So it's with great pleasure that I introduce Sandro Galea.
Good evening. Thank you very much, Phil, for that most generous introduction. I have, as Phil mentioned, known each other for almost 2 decades, and I have admired and been intimidated by Phil ever since, and so it's actually quite lovely to be introduced by him. And in fact, after an introduction like that, the best thing I should do is actually not say anything, because anything I say will be downhill from here. But since I'm standing here, I will proceed in a way through my fear. I'm delighted to be here. I actually really enjoy engagements which are intended to be interdisciplinary and intended to really provoke thinking that's beyond the usual, which is the charge that I got. And we call this talk Practical Philosophy of Health, and now I've sort of surtitled it a little bit. And I meant Practical Philosophy of Health in the sense of philosophy as being a way of understanding and understanding truth. And what my talk is really going to be about is a challenge to us all to say, when we think about health, we think about health the wrong way. And this is why, this is how we should be thinking about health. So really what I'm hoping you're going to get out of my talk is a new way to think about health and a new vocabulary that we can use in conversation about what we mean when we talk about health. So with that introduction, let me plunge in. You know, the motivation behind any talk like this is that there is a good reason why we should talk about health differently, why we should think about health differently, because there is a real problem. Now, my talk is still mentioned in his generous introduction. I've done a fair bit of work globally, but my talk is fairly domestically focused. We can talk globally, this is sort of a separate talk. But I want to just talk a little bit about the problems we have domestically and what are his challenges domestically. So let me start this way. So this is death from non-communicable disease in the United States. It's the red bar, and these are a whole range of other countries. So we kill more people from things like cancer and heart disease than any number of other countries. You know, every election cycle in the US, there's always this argument about us being like Denmark or not like Denmark. There's always somebody saying, well, we don't want to be like Denmark. And my reaction is always like, why not? But you know, but we kill more people than Denmark and Sweden, but also like, you know, more people than countries like Greece and Italy. You know, they can't get anything right, but they still kill fewer people than we can, which is always very sobering. And you know, we are, I can show you this for any number of diseases. We actually, compared to our peer countries, have worse health than all other indicators. And in fact, we have worse health at every age group. We're very consistent about this. So this is by age group right here. And the way, two things to look at here. Number one is you see this U-shaped curve. This is mortality. More people die in infancy, and then we go to a very safe period, which is sort of early young adulthood, adolescence, and then you start having death again. But all what you see here is blue versus red bar. The blue bar is the US, the red bar is other high-income countries. And what you see is that at every age group, we kill more people than other countries. So like, you know, we kill more infants, newborns, then you get into teenagers, young adults, middle-aged adults, and older adults. So this is a bit of an issue. And you know, most people who are sophisticated about health know this. Most people realize this, and sort of it's one of those things that we accept with a bit of a shrug. It's like, well, we're just not very good at health. And what we forget something very simple. It wasn't always like this. In fact, not so long ago it wasn't like this. So when you look back here, this is going back 35 years, 1980. These dots, this is life expectancy now, and these dots are the high-income countries. The red dot is the US. Look at this. So in 1980, 35 years ago, we were in the top half. And over the course of the past 35 years, we have drifted to the very bottom. So we essentially have brought this upon ourselves. We have made ourselves the worst performing country on health among wealthy countries. And we're not comparing ourselves to Somalia. It's not a fair comparison. We're comparing ourselves to high-income countries. And we have made ourselves the worst performing country. And in fact, when you look at this is the US again. And look, countries like Singapore, Japan, Costa Rica, Chile have surpassed us in life expectancy. They have gotten better, while we have been getting, not exactly getting worse. Well, in the past couple of years we've actually been getting worse, but we're not getting as good as we should be. And in fact, if you look at this slide is a bit ironically called American exceptionalism, because until about late 80s, the blue means that we were gaining life expectancy in other countries. And since about the late 80s, we have been losing life expectancy compared to other countries. Now, you might say, okay, well, that's a problem. Fine, I understand it's a problem. And maybe it's because we're not paying enough attention to it, we're not spending enough money on it, etc., etc. And it's not true. In fact, this slide looks at spending on health. And these colorful lines here are all the other rational countries in the world. You see, they're all increasing spending, but this is us. We are like way above everybody else. In fact, we're about 30% more than the closest competitor on spending. And you know, I would ask you this question. What other industry can you think of where we far outspend everybody else and get worse outcomes than everybody else? The answer is there is no other industry, there's no other sector. You know, people think about education. We don't outspend people on education. In fact, in education, we're right in the middle of the pile. Sometimes people say the military, outcomes are harder to judge in the military, so let's not go there. But in fact, imagine if I told you that we spend much more on our phones, but our phones are worse than every other country. You'd say, well, it's absurd. We wouldn't tolerate that. But we tolerate it on health. We tolerate it. We all in this room are responsible for this. We accept this. This is just how it is. And I just want to show you one last slide, and then we'll move on. This is a very simple slide. This is life expectancy, and this is spending. And what I want you to see all these countries, you spend more, you get more life expectancy. All countries are like that. But look at the US. You spend more, and we're sort of falling off the chart because our life expectancy is not gaining. So that is the problem. The fundamental problem is that we have worse health than all our peer countries, despite the fact that we spend much more than everybody else. So really what the rest of my talk is about then is, why is that? Why is that the case? And in a large part I argue that that's the case, because we are not thinking about the right things when we think about health. And in fact, when we talk about health, we should be talking about other things than when we talk about health. And just to give the structure of my talk, I'm actually going to suggest 10 things that we should talk about when we talk about health, which ultimately, to my mind, represent what I call here practical philosophy of health. They ultimately represent a truer understanding of health than we have in this country. So having said that, let me plunge in. First thing, we should be talking about health, not about healthcare. Before I explain this, I will pose a dinner table or a bar challenge to you all. Start a dinner table conversation or a bar conversation with friends casually about health, whatever you like. Say, I don't know, I was reading something about health in the US. We can start a conversation like that. And look at your watch and see how long it takes for somebody else in the conversation to use the word healthcare interchangeably with health. I promise you, it'll be less than 5 minutes. Because we conflate health with healthcare. Now what do I mean by that? So let me explain it. This gentleman, for those of you who know the blues, is Blind Willie Johnson. He's a bluesman. We remember him because about 30 of his songs have been preserved in time. He was born around the turn of the 20th century in Texas. He was sighted when he was born. When he was 7, his stepmother threw lye in his eyes and domestic violence incident, and he became blind. So he grew up poor, blind, black in Texas. He learned how to play the guitar, and he made a living busking, which is sort of why we remember him, because he was very creative, and some of his songs were preserved in memory. He got married when he was in his 30s. Him and his wife lived in a small sort of shack. It burned down, but they didn't have any money, so they kept living in the burned down house with this shack. Early 40s, Blind Willie Johnson developed malaria, and his wife took him to hospital, and he was turned away from the hospital. And it's not clear if he was turned away because he was poor, because he was black, or because he was blind. And then he died. So the question is actually a very simple one, which is what killed Blind Willie Johnson? Well, what killed him was malaria. Had he had chloroquine or some other treatment for malaria, he probably would have lived. But when I tell you that story, you all realize that had he not died of malaria that day, pneumonia was going to get him the next day. Had he not died of pneumonia the next day, something else was going to get him the day after. Because it wasn't just malaria that killed Blind Willie Johnson. What killed Blind Willie Johnson was malaria, yes, but also racism, access to care, domestic violence, homelessness, and poverty. All those factors killed Blind Willie Johnson. When I tell you a story like this, it's sort of like inescapable. It was like, oh, yeah, okay, that makes sense. That's the difference between health and healthcare. Spending all our money on healthcare means spending all our money on malaria treatment. And ignoring the fact that the malaria treatment by itself is not going to prolong Blind Willie's life. Now, you say, okay, what's nice? That's a story, that's okay. But what about in reality? What's happening in reality? Well, here's what's happening in reality. So this is, the bar on the left is a very simple representation of the causes of health. And this is actually quite difficult math to do, but broadly speaking, most people agree with this, that medicine and access to care contributes about 5 to 10% of our health. Our genes, maybe 20%. Our physical and social environments, about 20%. How we behave, about 40%. And a bunch of other stuff, 15%. That's what causes our health. This is what we spend our money on. 90% of our money goes on about 5 to 10%. 90% of our money goes all on medicine. So when I say to you, and I showed this slide earlier, that we spend far more money on health than any other country in the world, it's not true. We spend far more money on healthcare. We spend all our money on malaria. And we are not spending our money on all those other factors, the homelessness, the racism, the domestic violence, the access to care, that ultimately are ineluctably linked to health. Now, one of the things that happens when I give this kind of talk in sort of Massachusetts is, Massachusetts has a lot of good things going for it. We also have a bit of a superiority complex. It's like, well, okay, but surely this is understood in Massachusetts. After all, this is the densest concentration of physicians per person everywhere in the country. We must get this right in Massachusetts. And the answer is no. This is government spending over the past 15 years, state spending in Massachusetts. So we have increased our spending on healthcare by about 80% past 15 years, and we have decreased or kept the same our spending on primary, secondary education, law and public safety, mental health, public health, higher education, early childhood education, and environment. That's Massachusetts. I don't know what it's like in other states, but I'm pretty sure it's no better. So we are in a world where we focus only on healthcare. So what we need to do to think about health better is we need to stop thinking about healthcare and we think about health. That's point number one. Point number two. Health emerges over life lived. We tend to think of health as today. We tend to think of health as today. Today, I have in front of me a 45-year-old woman who's 25 pounds overweight and has arthritis in her knees because she's overweight. That's today. That's the health problem today. And we forget that presentation, that poor health that that person has, is a product of a life lived and inextricable from a life lived. And I was debating a little bit about how to show you this, and I can show you this. I'm going to show you one data slide. But I actually thought, again, I might show this a little bit more easily with a story. In this case, I want to show you the story with a cartoon. So here's the cartoon. So there are here two panels. The way to read this is you can sort of go down the left panel and the right panel. I'm just going to sort of go through quickly side by side. So this is a story of two people. Richard's on the left and Paolo on the right. So on the left it says, this is Richard, his parents are doing okay. This is Paolo, her parents not so much. Richard's house is warm and dry, his shelves are full of books, and his fridge is full of food. Paolo's house is full of people, and not much else. It's damp and noisy, and she keeps getting sick. On the left, Richard's parents will do anything for him, for their baby, good boy, clever. And on the right, so will Paolo's parents. That's why they're working two jobs. On the left, Richard goes to a great school, well-resourced, good kids, his teachers love their job. Paolo's school, the class sizes are large, the school is underfunded, and it looks like our teachers are tired, stretched thin from stress. On the left, so maybe we see why expectations in the report card, B+, oh dear, we need to get you a tutor. Might be slightly different for Paula. B, hey, that's not bad. Over the years, all these little differences add up. So Richard on the left, parents paying for university. Paula, juggling work and politics, still getting in debt. They start to add up to build something bigger. So dad says, I have friends working there, I'll have a word and get you an internship. Thanks, dad. Well, Paolo says, you should be finishing your studies, not looking after me, dad, you're sick. And because each little difference sneaks by unnoticed, on the left, yep, the loan is approved, congratulations. On the right, look, we can't help you, maybe try easy finance. Then maybe Richard starts to believe that he deserves to be on top, hit it by himself. Ah, you're Roger's boy, right? I've heard good things about you, have my eye on you. Maybe Paula starts to starts to learn her place. Okay, you've got the job, but I'm watching you, sweetie. And then on the left, we have a party where Richard says, congratulations, Richard, what's the secret to your success? And he says, less whinging, more hard work, I say. I'm sick of people asking for handouts. No one ever handed me anything on a plate. Now, did Richard work hard? Absolutely. Of course Richard worked hard. Richard worked hard all his life, there's no question. But Richard was floated along on an invisible hand of privilege that was handed to him. It was completely unearned, just like Paula did not deserve to be in a position where she's ultimately the one serving Richard on the plate at the end. Now, why am I showing this example? I'm showing this example because we forget this all the time. And we all in this room, every single one of us in this room, every single one of us in this room, in varying degrees, have a little bit of Richard. And we do not think about this. We constantly think about when it is that we actually are hit by a Paula circumstance, and we seldom think about the dozens and dozens of times when we get these kind of situations. So why am I showing you this? I'm showing you this because health is just like that. Health is just like that. Richard and Paula are heading to a different health profile. They're heading to a totally different health profile. Because Paula is working, she's on her feet all the time. She's going to be working 1 or 2 jobs. She's going to have to work hard to help her family make ends meet. She's living in less desirable neighborhoods. All those behaviors and social physical environments that shape health are going to be working against her. And we are going to have her being sick in her late 40s, early 50s. And we're going to say, well, maybe you should have exercised. Richard is going to be playing tennis when he's 51. And we're going to say, well, that guy looks after himself. And him looking after himself and her being sick at 51 is entirely a function of a life lived and unearned privilege. Now, I can show you a lot of data on this, and this is just one slide. This is a slide, this is a classic, what we call dose-response relationship. This is traumas you experience as a child and your likelihood of using cocaine. How often, when we see people using cocaine, do we say to ourselves, oh, she's using cocaine. I wonder how much of that is due to the trauma she experienced as a child. We don't say it. We say she's using cocaine. Depending on our perspective, and I would guess that the perspective of most of the people in this room is she shouldn't be doing that. Right? But it's directly linked to trauma experienced as a child. And I could spend the whole talk showing you how experiences, behaviors, and health conditions in adulthood are entirely linked as an expression of a life lived. So what should we be talking about? We should be talking about a life lived, and we should be talking about the life circumstances that ultimately shape health at a later point in life. That's number 2. Number 3, power, politics, and money. They don't just lead to health. They are health. They are inseparable from health. And I want to show you start by sort of this picture. I want to go back in time. This is 1863. This is the Civil War, U.S. Civil War. The U.S. Civil War was fought, of course, over the original sin in this country, slavery. But there were a lot of other things that happened during the Civil War that were emblematic of forces that were to come later. 1863, the Enrollment Act was passed. The Enrollment Act was the act that essentially conscripted men, I think it was between, I can't remember, 18 and 40, to join the Union Army. Except there was a clause in the Enrollment Act that said you could buy out of joining the Union Army if you paid $300. This resulted in the biggest riots that New York City has ever seen to this day. And it was riots mostly by poor Irish immigrants who felt correctly, that they had no way of ever buying out of this, and they were being conscripted to fight a war when other people were simply being able to buy out of it. And that, of course, is an enormous example of how money just buys you health. Now, let's talk about today. I suspect you're all thinking, well, okay, that was dramatic, it's dramatic. What about today? Are there other such dramatic cases? This is Arlington National Cemetery, and I'm showing you this because this is actually where we bury our war dead, and as well as many other places. And does everybody here know that since World War II, leaving aside World War II, when you add all the war dead, all the people who died in wars in this country, that those deaths are fewer than the number of people who've been killed by guns in this country? So we could fill all our national cemeteries since World War II with people who died by guns. And events like this happen. And we think that's dramatic. And how is this linked to power and politics? What's it with power and politics? Well, let me show you what happened after the Sandy Hook massacre, which of course killed children in their school. So this is after Sandy Hook. This is Sandy Hook happened right there. And there are 3 bars here. This is spending. The yellow bar is spending by groups on trying to promote gun safety, or what's here called gun control. The purple bar is by groups promoting gun rights. And the blue bar is spent on gun manufacturing. So Sandy Hook happened, okay? There was quite a bit of an increase in spending on trying to create gun safety. See, that's the yellow. But look what happened to the purple. That's what happened after Sandy Hook. So after Sandy Hook, which is the period of time when this country started paying attention to guns finally, we have been spending much more on gun rights arguments than ever before, and that they dwarf by a factor of 4 to 1 all our spending on gun control efforts. So when we say that all our cemeteries that are awarded or in could be filled by people who died from guns, it's not an accident. It's directly a result, it's completely intertwined with our political effort that's informed by that spending to keep it that way. That's guns, and we use guns as a sort of controversial topic just to get you riled up a little bit. But I can show you this in many other ways. Here's perhaps another example that should rile you up as much, but we tend not to let our heart rate go up as much about this. This is a very simple dose-response relationship here. On the y-axis, I have obesity. On the x-axis, what this is quartiles of subsidies. These are subsidies at the state level for us to produce corn, which results in an enormous amount of calorie-dense, nutrient-poor food in this country. The more we subsidize corn, the more obesity we have. It's actually pretty clear this is population. That is the power of politics and the power of money, and it is completely inextricable from health. So when we talk about health, if we want to understand health, we should think about the power of politics and money as the definition of health. That's point 3. Point 4. There is no health for the many if we exclude the few. And I want to talk about this in the context of, I don't want to talk about charity, and I'm actually going to get to charity in a second, and I'm going to tell you that I actually think that we should never think about charity when we talk about health. But I actually want to take this from a very, very pragmatic point of view. And I want to take it from a point of view, from a utilitarian point of view. So this is, folks know this gentleman. This gentleman is Jeremy Bentham. Jeremy Bentham is the father of utilitarianism. This actually is Jeremy Bentham. He is dead. But if you go to University College London, if you've been, Jeremy Bentham is mummified, and he sits outside the door of University College London. It's true story. All of him except for his face, because his face was eaten by moths and had to be recreated as a wax figure. True, I'm telling you story. But you can go. This is not a picture I took, but I had a picture like that in my own phone. Anyway, Jeremy Bentham is the father of utilitarianism. Utilitarianism is very simple calculus, which says that at the end of the day, what we should be aspiring to is simply to maximize welfare for as many people as possible. And that line of argument, the challenge with that line of argument is that it's often used to justify leaving groups behind. This leads to say, well, if we're trying to maximize as many people as possible, if you have a population of 1,000 people, we can help 900 people. It doesn't matter if we decide to bring it. And there's a whole rich literature on the moral challenges of that, but I'm not talking about that right now. Well, all I actually want to talk about is that when we talk about health, we should recognize that doing that endangers health for all of us, because all our health is intertwined. Now, what do I mean by that? Let me give you one example. Who cares about health systems in West Africa? It's West Africa. God knows what goes on there. And really, our health systems in West Africa are concerned. Again, leaving aside the moral argument. Well, they should be our concern if we care about something like Ebola. So, health systems in West Africa crumble, and you get Ebola in New York City and in Texas. And actually, Boston was miraculously spared from Ebola when it happened. Right? This is the kind of intertwined world where we live. Now, that's a dramatic example, you see. Are there other examples? Many, many other examples. This is Minnesota. Minnesota recently had a measles outbreak. Why did it have a measles outbreak? Well, because the anti-vaccine movement targeted Ethiopian immigrants in Minnesota, in Minneapolis, creating a reservoir of measles that then spread through the entire population. Those are infectious disease examples. Are there other examples? Here's another example. 10% of kids who are killed by cars in this country have nothing to do with the car itself. They're actually pedestrians who are simply killed by alcohol-impaired drivers. They have nothing to do with each other. Right? These are examples that I'm showing you that no matter what, unless you can put yourself in a bubble wrap, your health, whether you like it or not, is linked to my health. And my health is linked to yours. And when we talk about health, we need to talk about the health of the many. And we cannot, and from a purely utilitarian point of view, ignore the health of the few. Now, there are many of you here who are in this room who know much more about ethics than I do, and you can make the moral argument why that's also the case. But I'm just simply making a utilitarian argument that the health of the many is inextricable from the health of the few. So when we talk about health, we need to talk about the health of the many. Fifth point. We need wisdom and humility to understand health. Health is one of those phenomena that we all think we get, because we sort of all experience health, or at least we think we experience health, we think we understand health. And it requires humility to recognize that there's a lot we do not understand, and that our conception of health is often wrong. Let me show you, let me ground this historically. This is a picture of what we used to think generates health, which was a combination of blood and yellow phlegm and the green phlegm and bile. That's what these four quadrants show. And I stand here and I say to you, we used to think that blood, yellow phlegm, green phlegm, and bile are what caused health, and it was the body's balance of those that caused health. And did that actually have real consequences? For centuries, we thought that an excess of blood caused fever, which is why we used to bleed people when they had fever, which of course used to kill them. Now, when we hear things like that, we're like, well, okay, we're very foolish. You know, that foolishness lasted about 2,000 years. Like this actually came from the Greeks and lasted till about the middle of the 19th century. It was about 2,000 years we thought that's what caused health. So I'm here to challenge you and say, what is it that we think causes health today? That 100 years from now, forget 2,000 years from now, we're going to look back and say, well, that was pretty silly. Right? Because if you were sitting here in 1810, there was nothing silly about this. There was nothing silly about the fact that an excess of blood caused fever, and when people have fever, you should bleed them. That's what everybody thought. So what are the things that we all think? Well, you go on the CDC website. What does CDC think? Well, CDC thinks that the leading causes of death are heart disease, and cancer, and chronic lower respiratory disease, and accidents. That's what the CDC website says. Then about 20 years ago, another CDC analysis said, well, maybe that's not what really causes health. Maybe what causes health is not cancer and heart disease, it's actually tobacco. 400,000 people die from tobacco every year. Poor diet, that's another 350,000 people. Microbial agents, toxic agents. And then, about 10 years ago, our group did a paper which says, actually, 190,000 people die from low education, 100,000 die from poverty, 108,000 die from social isolation, 40,000 die because they live in poor areas. So, which one of those things causes health? Well, when you look at sheer numbers, this is just putting things side by side, but as many people, 190,000, die from low education in this country as die from heart attacks. About 180,000 die from social isolation or low social support, as die from stroke. Which one of these causes health? Well, they obviously all cause health. Does it matter? Does it matter which one of these we say causes health? Of course it matters. Of course it matters. If you say the leading causes of death are heart disease and cancer, you know what's going to happen? You're going to have the National Institutes of Health, which has a National Institute of Heart Disease and National Institute of Cancer. This is exactly what happens. If you say that what causes health is low education and low social support, you're going to have the National Institutes of Low Education, National Institute of Low Social Support. Do we have a National Institute of Low Social Support and Low Education? No, we don't. Of course not. Now, we're all sitting here saying, well, that's absurd. We should, of course, have the National Institute of Cancer and National Institute of Heart Disease. And I'm here to say to you, should we? How confident are you that in 100 years, the people who are sitting here in this room are not going to look back and say, can you believe it? They had institutes of cancer and heart disease, and they didn't have institutes about low education and low social support. You know, raise your hand if you have that confidence. I certainly don't. Because remember, 1810, I would have said, what causes fever? And you would all have said, excess of blood. Now, you say, okay, well, are these kind of battles like new, old? Well, they're old, they're actually old. This is these two gentlemen with the luxurious mustaches are two of the founding fathers of public health. Gentleman on the left is Edwin Chadwick, gentleman on the right is William Farr. And they were both very important figures in public health in the mid-19th century, when we were moving to microbial theory of disease, moving beyond phlegm and blood. And Farr on the right was one of the original counters of disease, and he actually produced a report that said that children were dying of hunger in London. Chadwick, who was a politician, issued a rebuttal and said, and there's a good quote, I think I'm getting it roughly right, which is, children do not die of poverty in civilized London. And so Farr says, well, look at my numbers, what are you saying they die of? And Chadwick says, no, they're not dying of poverty, they're dying of micronutrient deficiency. Does it matter what they said? Of course it matters, because if you say that people die of micronutrient deficiency, you're going to put all your money into giving them supplements. Well, if you think they're dying of poverty, you just need to fix the poverty. I go back to Blind Willie Johnson. If you say that Blind Willie Johnson all died of malaria, you can put all your money in developing pills for malaria and ignore everything else. So this is a tension that informs what we do, and it is a tension that comes about understanding what causes it. Fifth point. Sixth point. Health is a public good. When you start thinking this way, when you start realizing what causes health, and when you start understanding health in this way, you stop thinking that you own your own health exclusively. You start realizing that health is something that we collectively own. And you start realizing that unless we appreciate that, we are not going to improve our health. That the problem, actually, at the beginning, is going to continue, and in fact, is going to get worse. Now, what do we mean by public good? This is from John Maynard Keynes, which says, public goods are things that do not lend themselves to market production, purchase, and sale. They must be provided for everyone, they're provided for anyone. And they must be paid for collectively, or they cannot be had at all. Now, you all know that is absolutely not how we deal with health in this country. In fact, we totally produce, purchase, and sell health. We do not provide it for everyone, and we do not pay for it collectively. So in fact, we are dealing with health the exact opposite of how we should deal with health. Now, metaphorically, what do I mean by that? What I mean by that is, as you think about some of the pieces I'm telling you, you realize that if my health depends on your health depends on my health, if our understanding of health depends on health that ultimately is structured through a whole series of forces that we have no control over, it is inevitable that you think of health as public good. Now, you might look at this and say, well, it's impossible. How on earth can we think of health as public good? Well, we actually do think of a lot of things as public goods. This is New York City, and that's Central Park. We think of parks as public goods. Well, you're like, well, it's absurd. How else can you think of it? Of course, you can think of it differently. You can divvy up Central Park. Why not? There are 1.5 million residents in Manhattan, where I live, where Phil lived. You could say, I don't want to pay my taxes. I don't want to pay my taxes in part for a park that Phil uses. No, I want my part of the park, and he can have his part of the park. Now you're all chuckling. That's absurd. It's not any more absurd than how we deal with health. When you understand how health is produced, it is equally as absurd to say that that I can invest only in my health in isolation from your health, because it's simply not true. Are there examples in our current history that show us that? Absolutely. Here's one example. Flint. Flint, innocent, poor, unsuspecting residents of Flint drinking water that is contaminated with lead. Why is that? It's simply because we weren't thinking about this causing health that's a public good. We weren't thinking about the public structures that ultimately resulted in the health results of Flint. And I can show you many other examples. So point 6, health has to be thought of as public good. Point 7. The heart of health should be compassion. And we do not do this. I'm going to define compassion in a second, but the current state is the human emotion that we affix to health is charity, which sort of is a corollary of empathy. Charity means that I see you suffering and I feel bad. I see you suffering and I feel bad and I want to do something about it. If I were a corporation, let's say if I own Facebook, I might say, I feel bad that people are suffering, so I'm going to put $3 billion aside to end all disease in the next 10 years. That's true, that's exactly what's happening. It's what the founder of Facebook is doing. And that is we applaud that as a noble American impulse. It's a charitable impulse. The problem with charity is that it preserves the fundamental causes of what's causing the problem to begin with and does nothing to fix them. Compassion, by contrast, is different. This is a quote from Martin Luther King. True compassion is more than flinging a coin to a beggar. It actually comes to see that an edifice which produces beggars needs restructuring. That's what compassion is. Compassion says that we want to live in a world which is better, so we don't have to use charity and try to plug holes. Now, is it true that we actually don't operate on compassion? We don't operate on compassion. We operate on charity and empathy all the time. And now you're probably sitting there thinking, well, it's not such a bad thing to be charitable and empathic. Well, is that true? This is empathy at its finest. This is from some of our representatives on Capitol Hill after mass shootings. Saddened by the deadly shootings, with thoughts and prayers. Prayers for those injured and killed. Senseless shooting, heartbreaking, thoughts and prayers. Prayers for victims, families, students, staff. That is a classic example of empathy and charity that is not rise to compassion, where we actually don't say that is simply flinging coins, in this case flinging thoughts and prayers, rather than saying what is the fundamental problem. Compassion means understanding that the world is a better place by us all being healthy and putting aside the divisions and barriers to that. And absence of compassion is heart-rending when we actually expose ourselves to it. I want to show you this picture. This is Salome Carlo. She was one of the Times Persons of the Year in 2014. She's in Liberia. It's a country where I've done a little bit of work. She got Ebola. Salome Carlo, she got Ebola, and she was one of the people who survived from Ebola. About 40% of people die from Ebola, so people do live. And she survived from Ebola, and then when the Ebola epidemic hit again, she volunteered to work in the Ebola clinic with Médecins Sans Frontières, which is actually what this picture is. And she saved countless people working in the clinic after she had Ebola. About in 2017, so the picture was 2014, she was pregnant with her fourth child, and she had preeclampsia, which is high blood pressure in pregnancy, and her husband took her to the hospital, which is in Liberia, in Monrovia, Liberia. It's called JFK, it's JFK Hospital, and she was turned away from the hospital. You know why she was turned away? She was turned away because she had been an Ebola patient, and then she died. That is what a world without compassion does. And I show this with some trepidation because I simply don't want anyone to leave here saying Liberians have less compassion than we do. It's not true. We actually, we as a country are nowhere on the scale of thinking about health with compassion. I'm showing you a story of this thing. It's a very dramatic story. But this is the world. This is the world we're in. 1 in 7 children experience abuse and neglect. And last year, 20 people are victims of some sort of violence by intimate partner every minute. 1 in 2 women experience sexual violence. 1 in 5 men experience sexual violence. That is lack of compassion. That is lack of compassion that sees the world as a world which we should be striving for to make a better place. And I can show you data all the time. Racial segregation. This is Chicago, and what you're seeing here is concentration of blacks and whites. The reason there's dark and light areas is that's blacks, that's whites, and the two are totally segregated, which of course results in segregated patterns as well of life expectancy. We create a segregated society that bars us from contact with each other, and that bars us from creating compassion, bars us from creating the kind of world which actually doesn't just fling coins to a beggar, but deals with the structures that keep people as beggars. 8th point. Health should be a means, not an end. Now, what do I mean by that? We have a funny relationship with health. And forget health, let's talk about it now. How many of you here enjoy taking your car in for service? Right? In an ideal world, you never have to take your car in for service. You just want your car to drive. You have a preference in the car. You might like a flashy car, you might like a simple car, doesn't matter. You just don't want it to drive. But the car's health should just be a means to the end, and the end is driving. We should be thinking about health that way. We should not be focusing all our attention on health. In fact, health should be in the background and invisible to us. Now, is that true? Is that how we operate? Not at all. The way we operate is things like this. This is from times. This baby could live to be 142 years old because it reflects, of course, our obsessive focus on creating forever life through a whole range of genetic molecular approaches. I am here to break it to this baby that it will not live to be 140 years old. It's not going to be, it's cute, and it should live as long as possible. It's not going to live 142. That, of course, eludes us in much of our health investment, which is ultimately on forces like precision medicine, personalized medicine, which are really efforts to create longevity. And when you read, there's an enormous rich literature of, it's quite amusing in some respects, happening right now about trying to extend life. But in fact, the science, one paper just came out in Science recently, is pretty clear that there is probably a natural limit to life, which is about 115. This is what you're seeing is women and men, but they behave the same way. We can gain most life in the sort of 80 to 90 range, and then you see this happening here when you get to about 90, it's enormous steep drop off. We're not going to gain life expectancy. The reason is actually very simple, because ultimately human life depends on biological systems that are redundant, and we just burn through redundancies, and at the end of the day, we just start failing. This whole conversation about living forever is like magical fairyland unicorns on rainbows. I think it is not right. And when you look at this is deaths in the U.S. life expectancy is 79, and 80% of Americans, 90% of Americans die before the age of 94, and 98% of Americans die before the age of 100. There's no horizon on which we're anywhere remotely close to the promise of eternal life. We're 142 years old. We need to embrace the fact that we actually want to be as healthy as possible for as long as possible, and then with some luck, die healthy. And this brings me to mind the old tradition of memento moris. Memento moris used to be objects that were buried with people, and they ultimately were meant to remind us always that we're going to die, and to remind us to live well so we can actually die well. And that is different than how we think about it today. So point 8, we need to remember we're going to die, and we should remember to die healthy. Point 9, values. That we need to value health and to demand health. Unless we demand health, when you think about what I've said in this presentation, you realize that unless we demand health, we are not going to get health, and we're not going to get healthy. Here's a good example of demanding health. This is President Johnson signing Medicare into law. It's President Johnson, everybody remembers him, nobody remembers him. This gentleman in front is Wilbur Mills. Wilbur Mills chaired the House Ways and Means Committee, which was instrumental in clearing the financial resources for Medicare. Wilbur Mills was a lifelong opponent of the idea of Medicare until after JFK was killed and there was an election that swept LBJ into power. Popular opinion all of a sudden was demanding Medicare, and Wilbur Mills miraculously had a conversion and rode to Damascus, and all of a sudden he became a big proponent, and he gladly delivered Medicare to LBJ, who of course in his wily way had Wilbur Mills right there signing. This was because we demanded health. It's because our values changed and we demanded health. And one of the mistakes that we make in science, those of us in universities all the time, is we are rationalists, and we think that it's enough for us to produce the evidence that says what should make a difference. And in fact, the evidence has limited utility without the values to support it, without the demand for it. I actually published a piece which has a sort of simple 2x2 table on it, which says here, this is data. So here we know that things work, here we don't know if things work, but here we actually have the values that support something that works, and here we don't. So if you read this, look at polio. We know what will work to get rid of polio, and we're sort of all against polio. So that's easy, that's up here. You go down here, we actually don't know what really works to reduce gun deaths, and we're really messed up on how much we value guns and not. That's down here. But then you have off diagonals, something like Zika. We don't know very much about Zika, but we really don't like Zika. But then there's things over here, where we know how we limit the consequences of drug use. We know that supervised injection facilities will reduce the consequences of drug use, but we find those unacceptable, so we don't want them. At the end of the day, values and knowledge have to go together. And values keep us from doing things that we actually should want, and we do want. How many of you would prefer to live in a world where you have treatment for your Alzheimer's versus a world where you don't get Alzheimer's at all? Nobody wants to get Alzheimer's. Nobody wants to. It's like, we just don't want to get it at all. We would much rather prevent disease than cure disease. And what do we spend our money on? Well, we spend about 5% of our money on prevention. That is completely counter to what we value because we're not demanding it. Does the absence of prevention matter in this country? Absolutely. Since the late 80s, in this country, 70,000 people, mostly women, have died of excess breast cancer simply because we don't invest in prevention. 70,000 people. Why is that? Because we're not demanding it. We're not demanding health. We're not demanding prevention for health, is what we should be. Last point. We should be free to choose health. One of the objections to a talk like this, there are many objections to a talk like this, and I would welcome them afterwards, is that, I sometimes when I speak to unfriendly audiences, they will pull out the alien card and say, well, you don't understand Americans, because somebody probably introduced me and said, I'm not American. So you don't understand that we Americans value freedom. We value freedom. And you are trying to take away our freedoms. And my answer to that is, well, actually I have an answer to that, but I cannot say it. But my answer to that is that's actually wrong. It's not true. Because, where the ideas of freedom come from, some Declaration of Independence and Bill of Rights, etc. But we keep making a mistake. We keep thinking that by freedom, the only freedom that matters is freedom to do X. But the other freedom that is equally important is freedom from. It's freedom from Y being done to us. And we keep forgetting that. It is equally a freedom that is important, that we are not living in a world that generates obesity. This is obesity rates in this country. 2017, the darker colors are more states. It is freedom from being accidentally plunked in states where they are generating obesity. The argument keeps being fought on the freedom to axis. This is a cartoon about what was happening in New York City. When I was in New York City, I was on the health board and was part of the movement to ban large-size sodas. And of course, that law ultimately lost because of a lobbying effort by the soda industry with cartoons like this of Bloomberg, that's sort of this whole nanny state story. Ultimately, the idea was we want freedom to drink 32 ounces of sugary soda. But it is equally important that we have freedom from calories being thrust upon us unsuspectingly. Now you say to me, well, what do you mean by that? I'm aware of my calories when I'm eating them. Are you really? Are you aware of how the calorie counts of common foods have changed, say, in the past 20 years? Are you aware that the bagel 20 years ago had 140 calories and today has 350 calories? Did you know that when you had a bagel today? I mean, God help you if you had a muffin. I mean, it used to have 210 calories, now it has 500 calories. I mean, cheeseburger, and I know they would admit having a cheeseburger, but just to be clear, if you did, 20 years ago it had 300 calories, today it has over 600 calories. Freedom from is freedom from having a obesogenic environment thrust upon you. This is goes back to New York City, the neighborhoods in New York City. This is the darker color are poor neighborhoods, the darker color are obese neighborhoods. You have the two are almost completely overlapping. Because being in a poor neighborhood means the kind of food is available, the kind of food is high calorie, that has high calorie content. Freedom from is being freedom from being killed unwittingly because you don't see that's happening. Now we actually do understand this in many respects. We have actually acted and have allowed freedom from to trump freedom to. When have we done that? Well, one of the biggest success stories of the 20th century in health is this. This is death from cars. The blue line is death from cars going down, and the green line is we're driving more. So we're driving more, dying less. But for every mile we drive, we're 200 times less likely to die. Why is that? Is that because we're better drivers? Have you driven in Boston? No. It's because we have seatbelts and airbags, and because we have shatterproof glass, etc. You have lost your freedom to drive in a car with solid pane glass windows that when you hit something become large shards that cut your carotid and kill you. You no longer have that freedom. Do you miss that freedom? No. You have freedom from dying with a shard of glass from your windshield that cuts your carotid. So we've done it. In some cases, rare cases, and the notion is a canard to say that we only care about freedom to. It's not true. Freedom to should balance with freedom from, and we should want freedom from the things that make us unhappy. Now let me conclude. Let's conclude with one more slide, and I'm happy to take some questions. So I want to conclude with a sporting metaphor. And I want to talk about the only sport that matters in my household. I have 2 teams, and the only sport that matters is soccer. Last question, what's the best soccer team in the US? Anyway. So, because she gets it right away. It is. Because it's national soccer. It's by far the best soccer in the US. Now, for those who don't play soccer, here's how soccer is played. Because, I know that this country plays a different kind of football. It's a very simple game. So 11 people on one side and on the other, and they sort of kick the ball this way. 2 nets. And the players can only use their feet, hence it's football. Except for one player, in this case, a woman in red, her name is Hope Solo, very good goalkeeper, kind of nuts, but good goalkeeper. And the goalkeeper can use their entire body. They can be in that, they can do anything they want, they can stop the ball. Now, if you don't play soccer, you think, well, the way to win a soccer game is to have the best possible goalkeeper, because ultimately she can stop any ball, right? As long as she's good, she can stop any ball, you'll never have a goal against her. But when you watch a soccer game, when you see something funny happening, the goalkeeper is prowling in front of the net, and what she's doing is she's yelling at her other players. You know what she's yelling at her fellow players? What she's yelling at them is, keep the ball away from me. Now why does she do that? Because it doesn't matter how good you are as a goalkeeper. You realize the net's pretty big, and if the ball's going to come at you, sooner or later, you're going to concede a goal. Now why am I telling you this? The goalkeeper is medicine. At some point, we're all going to get sick. And we all want to have the best possible goalie, best possible doctor to restore us to health. The other 10 players are all the other forces that create health. They are the forces of compassion. They are the forces that create stable housing, create stable income, keep us safe from discrimination, make sure that there is equity across genders. All the other forces that ultimately create a healthy world. That's what the other 10 players are. Our challenge in this country, the fundamental problem is that we spend a lot of money and we spend it all on the goalkeeper. And that goalkeeper is health care in medicine, not health. So ultimately, coming down to what do we talk about health? We talk about the whole team. We talk about all these forces. And a a practical philosophy of health that understands that would be transformative. And as I see it, it's actually the only way we are going to reverse the losses that we've had in health in this country in the past 30 years. I'll stop here. Thank you very much for having me.
We have time for some questions, comments, and I'm not sure we need a mic if you can stand up if you've got a question.
Thank you so much for this incredible talk. I do literature and learn a lot. I do narratives. But I had one question. Your point about the difference between empathy, compassion, and charity. I'm not sure I got your point because it seems to me that what you're calling charity has a lot of compassion in it, and then empathy is like a necessary first, say, emotion for other emotions to take place. So could you expand your point?
Yeah, I was focusing much more on the outcome of those emotions than on the interlinkages between those emotions. I don't disagree that that charitable impulse can lead to compassion. I take issue with the fact that we stop at the empathic charitable impulse, which simply says, I am just going to help you with this particular problem, and then walk away from the fundamental issue. A compassionate approach ultimately recognizes that why is it that you have that problem, so we can fix it so it doesn't happen again. But I don't dispute, I think you're completely correct, that the emotions are linked, and I think an educated set of emotions can move us from a charitable approach to a compassionate approach. I don't disagree. But evidence that was pretty abundant that on many issues, and I showed the examples of gun violence, we actually don't move beyond the charitable approach, where we simply accept that that's enough, and it's just not enough. But thank you for the question.
Yes.
So a lot of us are probably going to be future healthcare workers. I guess a lot of people in public health, or even if they're going to do direct patient care. So how would you suggest that when we're working on our own to get people to see health and healthcare differently, even just little things that we can do just with our patients each time we see them?
Yeah, I think if your job is to be the goalie, you should be the best possible goalie you can be. Having said that, I think you should make sure that everybody around you recognizes that you're not going to win the game by yourself, that you need the rest of the players on the team. So there's nothing wrong with being a goalie. It is important. I want you to be a healthcare worker if that's what you want to be, and I want you to be as good as you can be at it. Just remember that that in and of itself is not enough, and that the global conversation is so heavily weighted towards the goalie that if you're going to be a goalie, you have a responsibility to make sure the other 10 players are recognized as well.
Yes.
She asked a very similar question to what I was going to ask, but we teach a lot of undergraduates here in public health, and I'm just wondering how you might advise undergraduates to take this philosophy of health and have it craft sort of their education, but also their post-undergrad experience. I mean, do you have advice for, when you are approached with education or news or anything else that might contradict some of these principles? How do you approach that in the classroom and outside the classroom?
I think you approach it by relentless communication of the message, by being clear that health is not healthcare, that the production of health depends on forces around us that we need to pay attention to, by being clear that we need to demand health in our governance, we need to demand health across sectors, be they private sector or public sector, and by expecting no less than a world that generates health, by saying gender equity is an ineluctable part of the world we live in, because without it we're not going to have health. There are plenty of other reasons why we don't have gender equity that has nothing to do with health, but health is a pretty compelling reason to make sure it's in the mix. And at the end of the day, the world changes when the conversation changes. So my point is that everybody who's training on this and who are not training on this need to make sure that we say this over and over and over again as clearly as possible. Certainly the other side, so to speak, which is the goalie-only side, right now is winning by a big margin.
And next to Nadia, yes.
I know you were predominantly talking about domestic applications of this, but if we were to project it to a global scale, would those tenets still hold, or do they change when you have different governments at play and the disparities are much greater?
Yeah, no, I think they largely still hold. The exigencies become so much bigger in some respects. The inequities that drive global differences become so much bigger that it almost becomes absurd to even make these arguments. That it becomes painful to even make them. I mean, your life expectancy in Malawi is 47, and your life expectancy in Japan is 83. And what did the baby born in Japan do to deserve being born in Japan versus the baby who was born in Malawi? Absolutely nothing. She just happened to be born in Japan, and he just happened to be born in Malawi. It goes back to the Richard and Paulo story that I showed you earlier. But I think the principles are still the same. I think I haven't done a more formal adaptation of this to global, but I think it applies.
Just an extension of that, as a U.S. agency or organization functions abroad, does that change their dynamic? Does charity become more important? That's the approach that they can take?
No, absolutely not. I actually think, in fact, it's part of the biggest problem with development aid right now. The development aid is informed by charity rather than by compassion.
So Sandro, if you were to put together a comprehensive program, either in Massachusetts or the United States, to combat gun violence, what would be the key elements?
Gun violence, we have to start with truly universal background checks. It's very hard to do it just in Massachusetts because there's a lot of gun usage just across the state lines. So you'd need to do it nationally. But you would do truly universal checks. You would create systems where you would take guns away from people who we know are likely to commit violence. You would create ballistic checks, not just gun checks. And you would remove weapons that are designed for war. If you did just those three, you would reduce gun mortality by at least 50%, if not 80%.
Research?
Well, research is, I think there's compelling evidence that suggests that what I just said is true and correct. There's no question that we are, I just had a paper just came out last month that says we have the lost generation of firearm researchers. But I think there's certainly enough evidence to act.
Andrea?
Thank you very much for a very insightful presentation. You stressed that we need to demand health as citizens or professionals.
Yes.
But usually what we experience is that we demand health for our own.
Yes.
My family, myself, my friends, my group. But it's more difficult to have a vision of demanding health for everyone, so a vision of the common good. So you presuppose this, and then are pushed back by instances where, on the contrary, we ask for health in a very narrow way. So what can help us to realize that we cannot ask health only for myself and my own, but then health as so intertwined, as you indicate. So what can help us to change our own way of thinking?
Yeah, I've heard a little bit about this. I think at the end of the day, stories are essential. And I think we suffer from a surfeit of medical individual health stories and not enough stories, like the Blind Willie Johnson story. I think part of the charge for anyone who's interested in health of populations is to tell better stories. In part, I sort of accepted a speaking invitation like this because it's rooted in the humanities, which tell stories much better than medicine does. So I do think that we need stories, and we need a generation of storytellers of how health really is produced. So it's a charge to everybody in this room who's younger than 30. It's a noble way to live your life.